Good afternoon, and of course, thank you very much for the kind of invitation and for the opportunity to join this very interesting meeting and also to visit again Cairo, which of course is a wonderful and never-ending offering possibility to find something new, to explore something very beautiful. I think that what we are doing today is to clarify something that is well known in clinical practice. We spend a lot of effort in order that our patients can lose the weight. But you know, the majority of cases, they not only go up again, but usually they gain even more weight than before. And in the past years, more recently, these aspects of weight control emerge as important key risk factor for several complications in diabetes. Of course, when you know that the overweight by itself is a risk factor for cardiovascular complications, there are two ways through which overweight can influence the risk for cardiovascular events. One is direct effect. Obesity or even overweight is accompanied by chronic low-grade inflammation, which of course is, is highly linked to the risk of CVD. But there are other intermediate risk factors, which is the possibility to develop diabetes. Many times this that is accompanying dyslipidemia and hypertension. We know very well this is the concept of metabolic syndrome, so nothing new. But what is now emerging is that when over time this weight goes up and down, maybe there is something different that just related to the overweight or obesity by itself. There are several ways to define the weight variability, and you find on the right side of this slide the different definitions. Usually, the one of the most used in research is to use the standard deviation of body weight over time in order to have an idea to measure the variability of weight in a period of time. What we will touch shortly, do not mind, is how body weight variability and cardiovascular disease are linked in people with both type 1 and type 2 diabetes, but also in people without diabetes. How body weight variability could also influence the appearance of microvascular complications, at least in type 2 diabetes, where we have evidence, as body weight variability can influence other health outcomes, and of course, how this phenomenon can work in increasing the risk for cardiovascular disease. And finally, what can we do to avoid the weight variability in people with diabetes, but also without diabetes? Let's go to the evidence linking body weight variability and cardiovascular disease. You know, the first evidence was coming by this very old paper, 91. It's a study coming out from the Framingham Heart Study. I think that everybody in the room knows this study. It is an epidemiological study looking at all the population of the city Framingham, and it was coming out that the body weight variability in time in people without diabetes was a strong predictor for cardiovascular disease. You know, this effect of body weight variability was defined as yo-yo effect. I don't know if you know the concept of yo-yo. It was a very old tool used when we were young. Now I think it's almost disappeared, but this concept at that time was defined, the yo-yo effect, meaning go up and down, up and down. What evidence we have about more specifically in diabetes? This study, published a few years ago, reported that body weight variability was found as a very strong independent risk factor for cardiovascular disease in Asian people. You know, Asian people, they have different characteristics from Caucasians, because the concept of obesity in Asian people is linked to different BMI, for example. They are more slim, but anyhow considered in overweight. So we were looking at the possibility that body weight variability was also linked to cardiovascular disease in Caucasian people, and we used the Swedish Diabetes Registry. We cooperate with this registry. Many of you, I'm sure, know that the Diabetes Registry is one of the best in the world because it's following all the people living in Sweden. Really, they are collecting all the data of people living in Sweden. So it's one of the more complete registry in the world. And we found out that body weight variability was strongly correlated to high risk for cardiovascular complication also in Caucasian people, and there was no influence of sex. So if you are a woman or you are a male, there is no difference if your weight goes up and down in terms of cardiovascular risk. And also, this is a meta-analysis published just a few months after our paper, showing that pulling all the data, available data at that time, about body weight variability, this was confirmed as a strong predictor for cardiovascular disease, but also that ethnicity is not influencing the result. So this is another piece of the puzzle, meaning no sex influence, no ethnicity influence. So in other words, everybody in the world who has this weight going up and down in time is a high risk of developing cardiovascular complications. And also, what about type 1? There are only few data available, but again, you see that also data from the DCCT, I believe that anybody knows that DCCT is the trial performed many years ago in type 1 diabetes, confirms that high body weight variability is associated with increased risk of MACE and all-cause death in people with type 1 diabetes. So also in this kind of patients, it is confirmed that body weight variability predicts cardiovascular disease. But what about microvascular complications? We have some data in type 2 diabetes. You see here that in this paper, there is a post-hoc analysis of the ACCORD trial. You know that also this was a very important trial performed in the States. And there was an independent association between body weight variability and not only macrovascular complications, so this was confirmed, but also microvascular complications. But not for all. Because in this paper, the authors look at the correlation between body weight variability, nephropathy, neuropathy, or retinopathy. And what they found, that the body weight variability was associated with high risk of developing neuropathy, nephropathy, but not retinopathy. Why? Honestly, nobody knows. But this is the data. So what I mean, it seems that retinopathy is not so much influenced by the body weight variability. But what about body weight variability and other health outcomes? The worst evidence is that if somebody goes up and down, has a very high chance of developing type 2 diabetes. So it's not only obesity or overweight by itself a risk factor for developing type 2 diabetes, but also if you go up and down in time, you have even higher risk of developing type 2 diabetes. So it seems that something that must be avoided to preserve people from developing type 2 diabetes. But how this works? Meaning, okay, why if the weight goes up and down, it can be even more worse than having a stable overweight, because this is the key question. These are some in animals, but I will show some also in human studies. And trust me, there are not so many papers on this topic in terms of physiopathology, because this concept, even I show you that the first paper was published more than 30 years ago, this concept has raised the interest only recently when some evidence was coming out again. You see here that in these mice, which were fed in order to remain, to not gain weight, to gain weight and to be stable in this high weight, or to go up and down in weight. And some aspect where some pathophysiological pathways were explored. At the end, what was coming out, just in summary of these very complicated pathways, that an exaggerated adaptive immune response in the mice in which the weight was going up and down may contribute to the negative effects of weight cycling. And you see here that in this study emerged the key role of adipocytes. Of course, which organ is influenced by weight variability? The adipocytes. They can grow and they can break. They grow and they break, because by definition, weight increase is related to fat increase. And this is another study, almost the same design. You see normal control group, obesity group, and weight cycling group. On the right side, you see the curve of the weight. And the results were that compared to the animals in a stable high weight, the animals having a weight cycling had an impairment of systemic glucose metabolism and systemic insulin sensitivity. So meaning that at the end of the day, because the adipose tissue changed the shape, it appeared an insulin resistance, which is conceptually not difficult to understand. And also, of course, this affected serum lipid levels, because if you have insulin resistance, by definition, you also have an alteration in the lipid metabolism. And you see here also more interesting data from the same study. The key role seems to be related to an increase of adipocyte size. You know, the number of adipocytes increases at the beginning of our growing. A child has a number of adipocytes. If he's obese in the childhood, this number increases. But usually later, the number of adipocytes does not change. But what changes is the size. So if somebody is accumulating fat in the adipocytes, there is no change in the number, but there is a huge change in the size. And from this study is emerged that probably the adipocyte size is playing the key role in producing the bad effect of weight cycling. And at the end of the day, we propose this kind of hypothesis that weight cycling affecting adipose tissue, particularly adipocyte size, can lead to an increase of inflammation, or inflammation, meaning you see here several inflammation factors, IL-60 and F-11, which in turn can favor immune cells recruitment, and again, in the vicious circle, you have not only a local, but also a local low-grade chronic inflammation, which is the basis for development of several diseases, including diabetes, including cardiovascular disease. But what we suggest as hypothesis is also based on only few in vivo studies in human studies. You see here again, in this study, there was some over some going up and down of weight, and a lot of pathways, or a lot in different tissues, also including microbiome and so on, was very, very, I think, elegant study, because it was looking at several possibilities. And the final effect is, of course, it's very complex, sorry, a slide, but the result is that weight gain is associated with the activation of a strong inflammatory and hypertrophic cardiomyopathy signature in blood. And then even weight loss reverses some change, a number of signature persist, long-term physiological changes. This is the clue, this is the problem. It's like, I think that you noticed the concept of metabolic memory, legacy effect of hyperglycemia. There are some changes induced by weight cycling that if you stabilize the weight, unfortunately, they are not reversed. Some are reversed, but some are not. And probably this explains the long-term dangerous effect of weight cycling in time. What about the strategies, the future strategy? First of all, the less younger may remember the Mr. Fit, which was the first study, epidemiological study, showing that when you add a risk factor to another risk factor, the final effect is not the sum, but it's exponential results in terms of increasing the risk. And when you add to different factors, accumulating risk factors, diabetes, the story is even worse. This is a very old concept. It was published in 91. So it's a really old concept. But we know today that many factors, many risk factors are going up and down in humans, particularly in diabetes, because in one person, in one patient, you not only may have weight variability, but at the same time, you may have glucose variability. I think that you know there is a very strong topic today. But also you may have lipids variability, blood pressure variability. So what happens when all these variabilities are combined in the same person? This is something clinically very relevant. And we were exploring this concept, again in cooperation with the Swedish Diabetes Registry. We were examining all these many risk factors, body weight variability, A1C, blood pressure, lipid parameters in terms of variability. Of course, all these data were corrected for baseline value. So this is the approach. And we were able to show that, unfortunately, weight variability is the stronger first risk factor for cardiovascular disease in diabetes. If you associate weight variability with the systolic blood pressure variability, the situation is even worse. But the key message is that weight variability is the beginning of the story. Are you surprised? I am not, because you know, when you control the weight, at the same time you are able to control glycemia, blood pressure, lipids. So clearly, always we already knew that this is a key strategy to control the cardiovascular risk in people with diabetes. So it's not surprising that body weight variability emerges as the most important risk factor compared to the variability of the other risk factors. What we can do? There are several possibilities. We can low glycemic index. The data are not so clear. We know that metformin has some activity in reducing the weight, as well as GLT2. But clearly, the GLP-1 receptor agonists are the stronger. And we have evidence, because we started with the liraglutide, now then with semaglutide, which is stronger than semaglutide in reducing a weight loss, and at horizon there is also tirzepatide, which also has a strong weight reduction activity. So there are good news. What is the bad news? Is that until you get you take the drug. This is a step 1 trial extension. You see, this trial was clearly showing benefit of semaglutide in reducing the weight. We know very well this. The problem is that when you stop, people are regaining weight. So this clearly means that there is no chance. If you have to control weight with the drugs must be taken all life long. Otherwise, all the other chance is to convince your patients to follow a very tough diet to keep stable the weight, something that in practice is very complicated and difficult to achieve. So the message is body weight variability is today probably one of the most relevant and important risk factors for cardiovascular disease, and maybe not only for cardiovascular disease, in both type 1 and type 2 diabetes. The only chance is to reduce the weight, but to keep the weight stable in order to avoid the risk. Hard job for doctors, but more hard job for patients, trust me. So thank you very much for your attention.